about that.
What I'd particularly like to do is speak about the two big bills that we followed, and let you. But even beyond that, I think Bruce and Karen touched on it last meeting. But I would like to actually give you a little bit of background on why those bills were even created and what they were aimed at, along with what the result was in the legislation in our last legislative short session. So with that, I'm going to go ahead and launch in. I did want to let you know these slides, I just edited one of the slides, but most of these are from actually a public hearing. So I'm going to speak about two things: the corporate practice of medicine bill, which I'll start out talking about. That was the bill introduced by Representative Bowman, and that was HB 4130. And then I want to talk about the pharmacy benefit manager bill, which was HB 4149. So without further ado, so why is corporate ownership a concern, and what are the trends? And really that was brought up when Senator Bowman first brought the bill up in the House Healthcare Committee. Oregon is actually doing pretty well compared to the rest of the country, but with these slides are really showing where it's all going, and where it's going isn't a good place. And so really the legislation is trying to head off things from getting worse, and much worse. We can talk. I think everybody's probably pretty familiar with what happened with Optum and the Corvallis Clinic. But this is a nationwide trend, so I really want to address that. So as far as corporate ownership of medical practices, which is what this bill was really trying to address, there's really two types. There's hospital ownership of private practices, and then there's corporate ownership. So corporate ownership takes into account like private equity, places like BlackRock, and private investor owned organizations, and then insurance companies like United Health, and now retailers and pharmacy owners are getting into this. So Walgreens and Amazon. So just FYI, if you look at this chart on the bottom, it's showing you that just in the last 3 years between 2019 and 2022, and look at that increase in doctors that were employed by either hospitals or corporations. So the chart on the right says, is anticipating that only 1 in 3 doctors will be independent by 2016. It's kind of an older chart. But if you look at the chart on the bottom, that's more accurate, which is only a quarter of doctors anymore are not employed by a hospital or a corporation. So with hospitals, that's called vertical consolidation. So when you take over a practice that's kind of doesn't address what your main focus, like a sub practice, that's really what vertical consolidation means. So even though in the this bill in corporate practice of medicine in Oregon, really hospitals are kind of exempted. So I'm not going to really focus on hospitals much here, but just to show you that just in this 3-year period here, there was an 11% increase in the amount of doctors employed by hospitals. Really the issue is corporate, like private equity, insurance companies like United Health. And if you look at the trend here, this is what is really so kind of discouraging and alarming is this trend. So you can see just in this 3-year period, there was a 43% increase in the number of physicians that were employed by a corporate entity. And as far as practices, it's even worse. So in that 3-year period, there was almost a doubling of the amount of physician practices that were owned by corporate entities. And it's not just numbers. Like if you look, not just numbers of practices, if you look at what the amount of money that's involved, it's staggering. So just in this less than 2-decade period, the amount of private equity investment in healthcare has gone from 5 billion to $100 billion, and that was in 2018. So it's like 100,000% increase just in the last couple of decades. And why is private equity interested? Because obviously they're only interested because they can make money. So you'll see in some of these other slides, private equity doesn't go, they're not doing this for the health of the patients. They're doing this so they can flip the practice and make money on it for their investors. So how do they do this? Well, one way to do this, and you probably, I don't know if you've heard this acronym before, but MSO is a management service organization. So what this is a lot of physician practices, they don't want to really do all the paperwork and billing and accounting type stuff. So what they'll do is they'll farm that out to what's known as a management service organization. Well, the thing is that private equity and corporations can kind of use this as an in and a way to contract around having to follow rules like they would if it was like a physician-owned practice. So it's empire building. So the private equity will go ahead through the MSO and acquire these practices and the doctors underneath them, and they'll purchase non-clinical assets, and that's kind of their way to get into it. I think I got a different slide coming up that shows it a little bit better at the end, but so what's the big deal? So we have private equities buying practices. Well, that JAMA, for those not familiar with it, that's a Journal of American Medical Association. There was a study done. This is out of a study done by in 2022. So as you would expect, when private equity is in there, they'll want to, prices will go up, charges will increase, and Bruce spoke to this, I think, last week, moral injury. So what they'll try and do is increase the volume, the number of patients, which usually means decreasing visit times. So all these things are kind of geared to kind of eke more profit out of a business. And again, that's really the goal, is is getting the profit out of the business, which is not what we like to think that our physician practices are what we go for. So when private equity gets in there, this is an interesting graphic here, because when private equity actually sells a physician practice or a network, actually 65% of the time it's sold to another private equity investor, and only 20% of the time it's sold to some corporate entity like Optum or CVS or Amazon, and a very small amount of the time it just goes public from private equity. But you can see, this is really meant, when private equity gets in there, they're really trying to maximize profit in a short period of time. And we can talk about other things they do, like charging, buying a hospital network and then charging the hospital for the rent for the land that they're on until they go into debt, and then they turn around and sell the hospital network after they've gotten their profit out of it and the hospital network has gone into debt. So there's all kinds of really kind of devious ways that private equity will get their money. But really want you to look at that buyout part, because really that just shows, they're really in there for a short term, and they're really in there just to maximize profit. This isn't directly related, but I just mentioned it. I think it's an interesting chart, because this shows kind of how insurance companies are getting into this, getting into the market, and it's through Medicare Advantage. And this shows that, even in Oregon, really we're at over 50% now of Medicare enrollees are in Medicare Advantage plans. So through Medicare Advantage, ACOs, and I think everybody who's with Samaritan got that Belong Health letter, which is an ACO. So these are just ways that kind of this creep is getting into our healthcare system. So Optum, right? I think everybody's heard about Optum and with Corvallis Clinic. I mean, this is one example. Now, United Health is like the biggest the biggest insurer in the country, and actually the 10th largest corporation. So Optum is a wholly owned subsidiary of United Health, and they actually own or control 70,000 physicians across the country and 2,200 clinics. So that's far and above any other corporate entity. So, and as you're all aware, Corvallis Clinic just got bought through emergency exemption to avoid the healthcare market oversight review. So Oregon is, even though we've been pretty good, we're going that way. And Optum already, for those of you who don't know, Optum already bought the Oregon Medical Group, which is in Eugene. And we can talk about the effects of that, but I mean, already 32 doctors have left that practice, and I've been told 13,000 Oregon Medical Group patients have been told they're losing their provider and need to look elsewhere for medical care. So that's a nightmare that I hope doesn't come to Corvallis and Corvallis Clinic, but Lord knows. So United Health Group, so they own Optum. Optum is buying these practices, and they also have deals directly with pharmacies. Like this is showing they cut a deal with Walmart, so now they're directly collaborating with Walmart, and there's 5,000 pharmacies involved in that. And it's not just United Health. So CVS has 10,000 pharmacies. They recently purchased Aetna, the insurance company, and they've also just purchased Oak Street Health and Signify Health. So that's 10,000 clinicians. Oak Street Health is 600 PCPs and 169 clinics. So you can kind of see how this is going. So how do we ensure that doctors actually control doctor practices? So there is something called a corporate practice of medicine doctrine, which is supposed to ban just electricians or plumbers from running doctor clinics. Sorry, I didn't mean to pick on trades there, but you know what I mean. We should have doctors that are running physician practices. And the interesting thing, this ban on non-physicians controlling medical practices goes back to the 1800s. And so this stems from basically, trying to prohibit unlicensed practice of medicine. You don't want to have, again, going back hundreds of years, the blacksmith practicing medicine. It's we want doctors doing that. So, and the source of this doctrine can be either state statutes, common law, or through administrative actions like an attorney general opinion or medical boards. So we've had this corporate practice of medicine rule for, almost 200 years. So what's the problem? Well, the problem is this: starting in the 70s and 80s, we had this managed care revolution, with HMOs starting up, and along with this, physician ownership of corporate structures, or it should be corporate ownership of physicians practices, were relaxed. So professional corporations are still under the ban, under this regulation, But LLCs and LLPs, which are limited liability companies and limited liability partnerships, which a lot of physician practices are, have not been controlled. Also, there's been exemptions for certain types of providers, like hospitals are exempt, as I mentioned at the beginning, and HMOs are exempt. So along with this kind of relaxation was also, as you can imagine, corporations have lots of lawyers on staff, and they figure out how to contract around these bans so that they can still control the medical practice, even though they don't formally own it. So this is kind of, as I mentioned, this is how they get around it. So there's this MSO model, the Management Services Organization. So they're contracted to run the practice, but in essence, they basically exert the control over the practice. And how do they do this? Non-compete clauses where the doctor can't leave and open up their own practice. Gag clauses where they can't speak out against what the MSO or the corporation is doing. Setting schedules, workload, like doctors are responsible for a certain panel of patients. They increase that. They purchase assets from the practice. So there's all these methods that they can, even though they don't technically own the physician practice, they basically control it and control the doctors. So the Oregon Supreme Court recognized this ban in '47, so it's still law today, but it's been weakened over time. Like I say, professional corporations are still are permitted, but LLCs and LLPs do not have to have majority MDs own the practice. And there's also these express exemptions. And then again, there's all these ways that corporations can exert control over the practice without actually technically owning it. There's also kind of a little issue with lax and unclear enforcement. So there's only been a couple of cases enforced since the 1940s. And then, who is going to enforce this? Is it going to be the Attorney General? Will it be the medical board? Like, that's kind of up in the air. So all these things kind of, you can imagine lawyers, chomping at the bit whenever they see vulnerability somewhere. I'm sorry if there's any lawyers watching this, but I'm sure, lawyering can be a very beneficial practice, but I'm talking about, under certain circumstances, one lawyer can beat up another, and if that lawyer is employed by a major corporation, then that can be not a good result.
Alex.
Yeah.
Your co-chair of the is a lawyer.
All right. So
just had to get that in there.
All right. So I'm going to just shut up about lawyers then. So because Karen will be very pissed off at me. So Rep. Bowman introduced the bill. He actually introduced the bill last full session to address this problem, and he just revised it for the short session we just had. So that bill was HB 4130. So the main thing is, you'll see these are really the bullet points of what it did. So first, it closed the loophole that, if it's an LLC or LLP, it still has to be licensed practicing physicians that have majority control of it. And here's the other thing, which is interesting, because I watched all the healthcare committee meetings, and there was, as you can imagine, there was pushback from practices that were corporate controlled. And there was also some pushback from Republicans on the healthcare committee. The thing is, this doesn't prevent private equity from investing in practices. So some people were saying, well, we need external money in order to grow our practice. So the law would not prohibit that. All it means is that 51% of who owns that clinic needs to be physicians. So, for example, you know, if Corvallis Clinic wanted to sell 49% of their practice to a private equity investor, they could do that under this bill, and that would be allowable. So it doesn't prevent corporations and private equity from coming in and investing in practices. It just means that control has to be with physicians. So that was one thing, a huge loophole that the bill would have closed. The other thing is, you know, it would ban non-competes. It would ban these non-disparagement or gag clauses, you know, that force doctors to stay on staff. It would just basically keep, excuse me, it would basically ban them from a lot of these creative contracting practices in order to take control of a clinic, even though they don't technically own it. The fourth thing it would have done is, you know, you can imagine this is a very opaque process. And so the fourth thing it would have done is require ownership to be reported, so we know who owns these clinics. Is it United Health? Is it Amazon? Or is it the doctors? To let you know the result of this, so the bill did, Governor Kitzhaber testified in favor of it. Public comment was overwhelmingly in favor of it. It passed the House 42-12. And for those who don't know, I mean, I think there's 37 Democrats in the House, so it had bipartisan support. Unfortunately, it was killed in the Senate. There were a few Republican senators that used some procedural rules to delay a vote. And so when you know, we have a short session, it's only about a month long, or actually it's more than that, but the short session ended and the bill did not get a vote in the Senate, unfortunately. So that's kind of the bad news. So, but the good news is, I took part in kind of an after action meeting with Senator Bowman and some other folks. So it will be coming back in the next full session. So expect your legislative committee to let you know about it so that we can advocate for it. The good thing is two good things about it is, in order to get the bill through, try and get the bill passed quickly in the short session, Rep. Bowman removed this disclosure requirement because it would have had to go to Ways and Means Committee and slowed the whole thing down. So that wouldn't have been so good. So when it comes back in next year, it will have that disclosure requirement in there, which is good. The other thing is, the bill had a 7-year implementation delay. And you still had, you know, people in practices saying, well, 7 years is too quick. It's like, you know, we're losing practices left and right. And, you know, so 7 years was really long. So expect when the bill comes back next year that it will not have nearly so long an implementation delay. So they do need the delay so that, you know, doctors and practices can gear up towards it in the future, but it will be a lot shorter delay. Okay, how am I doing on time here, Mark? I got 10 more minutes.
Oh, easily, yes.
Okay, so that's one bill. The other bill I wanted to mention was HB 4149. This is Pharmacy Benefit Manager, or PBM, reform and transparency. So why did we need a bill about this? Well, if you look at this chart, it's showing you how many independent pharmacies Oregon had in 2018. On the left, if you look on the right, that's how many we had in 2023. Well, guess what? 35 pharmacies have closed. 35 independent pharmacies have closed. And the number just keeps going up. I think everybody knows, you know, Bimart has stopped filling prescriptions here locally. And why is that? Well, if the pharmacy is not getting, if the cost to dispense, to buy and dispense their drugs is not being reimbursed completely by the pharmacy benefit manager, it's a losing proposition. I mean, any business can't stay in business if they're just bleeding money. And that's literally what's happening with independent pharmacies around the state. And why is that happening? Well, you know, if a pharmacy could, for each drug that it wanted to, if it could negotiate directly with a wholesaler, it might be able to save some money, but pharmacies can't do that. They just can't take for each drug to try and negotiate terms with a wholesaler and then to the manufacturer. So pharmacies are basically forced to go through PBMs, or pharmacy benefit managers, and the pharmacy benefit manager reimburses the pharmacy supposedly, and is reimbursed by the insurance company, which is reimbursed by the insurance company. So if you look at, so you can see it's a bit convoluted there. I really want to draw your attention to the middle of this slide where it says negotiated payment. So the pharmacy has to, you know, has a supposed contract with the pharmacy benefit manager, so they negotiate a payment for their drugs. Well, the pharmacy benefit manager has ways that they can actually not have to pay whatever the negotiated payment is. And not only that, they have things like clawback clauses where they can actually, if the pharmacy sells a drug for a certain cost, and the pharmacy benefit manager can say, well, you could have sold it, you know, you could have bought it for this amount of money, so we're going to claw back that extra money that you got for ourselves. So the pharmacy, the PBMs are basically middlemen that are drying up, you know, they are really the cause of a lot of these pharmacies, independent pharmacies, not being able to stay in business. I found this little interesting fact that Secretary of State here in Oregon did an audit, and out of $1 billion in outlays in drugs to our CCOs, PBMs basically got $300 million of that. I mean, that's just an astounding amount of money. So, and it like you needed any more disturbing thought about, you know, the intrusion of these large and of the kind of this vertical relationship between pharmacies and PBMs and then the insurance companies above them. I mean, these are all relationships where, you know, where vertical businesses relationships, I mean, they're, you know, it's one conglomerate from the service and the pharmacy right on up to the insurer. So you can see, you know, for example, you know, Aetna's goes through CVS for the PBM, and then their CVS is their pharmacies that distribute, you know, and across the board. So, and a lot of this is actually, you know, and these contracts are actually pretty opaque. So one thing that this bill would do, number one, it would require PBMs to be licensed with the state, that they can't discriminate or retaliate against pharmacies. There can't be these clawbacks or new extra fees. And that also the reimbursement formula would be revisited. So it would look at dispensing fees and establish dispensing fees for the pharmacies. And also, again, transparency and reporting. So this bill was originally introduced that way. Now what happened, the unions kind of got upset a little bit. So they asked that ERISA benefit plans health benefit plans be excluded from it. So the Representative Nathanson, who brought forward the legislation, agreed to amend it that way. Then there was also cost concerns. There was a lot of pushback about regulating the cost. So what happened was she amended it to address those two things. So unfortunately, the reimbursement formula would not be included in this, but at least the transparency reporting requirement was in there. And again, the licensing and unfair practices were in there. So I can report, it's nice to at least report good news. And the good news is the bill actually passed. So in the healthcare committee, believe it or not, Representative Deal, who's a Republican, voted against it in committee because he didn't think it was strong enough. He didn't like that it was amended to make it weaker. So I just want to let everybody know, there was pushback on the corporate practice of medicine, but there's a lot of anger towards what drug companies are doing, what PBMs are doing, and the state of drug prices in the state. So the bill passed with overwhelming support. It passed 55-1. I mean, can you imagine in this day and age, like unanimous passing in our legislature? It just doesn't happen. And in the Senate, it passed 23-3. So the good news is there's a lot of people who are upset about drug pricing and our legislators want to do something about it. So that's what I have. So again, stay tuned. Next year, we're going to be following the next incarnation of the corporate practice of medicine bill, and we will be asking advocates to weigh in. I mean, your legislative committee gave public comment on these bills, and so we're going to keep following that, and hopefully we'll get that passed next year. So if there's any questions or comments, I'm open for that. Mark?
Yes, please. Questions for Alex?
I left the mine in the chat box.
What was that, Susan?
I left 2 of them for you in the chat box.
Oh, okay. Thanks. Karen's got her hand up.
Okay, Karen.
Okay, I'm a detailed person. I was visiting my daughter. She works in Central Oregon for the Independent Practice Association. She's a care manager, and she had a pamphlet. She had a notepad with Optum, and I go, Rachel, what do you have to do with Optum? And she says, well, we have a contract with them. So with Pacific Source, Medicare Advantage, she drops codes for all those patients only on Medicare Advantage plans, not for other Pacific Source health plans. And what they do is they track the codes for that patient every time the pharmacist sees them. And if they don't drop the right codes, Optum will tell them, oh, does that code change? And I was wondering, is that a HIPAA problem? If they're sharing all that patient information to Optum, do they have permission to have all that patient info? I don't know. I'm a detailed person, but I just wonder these things, sharing patient information with this outside organization that, tracks codes for patients.
I do not know the answer to that. I mean, Fritz, did you want to weigh in on that?
Yeah, I can. It is not a HIPAA violation because it is within the rendering of service to the patient. So anything having to do with medical billing or any kind of service, if that's a part of the contract, it's not a HIPAA violation.
Thanks, Fritz.
Yep.
Yeah, I don't pretend to be an expert on any of this, but I just try and keep informed enough to advocate. That was a good question, Karen. Anybody else?
I can read mine and get my chat box up. The first one is Dan Rayfield is a lawyer as well, besides Kelly.
Oh, okay. I'll look at I've been a little busy, Susan. I'll look at the chat and reply to you, okay?
And then the second one, what kind of surface are you saying?
Well, oh. What kind of services am I
Yeah.
saying about what now?
I saw what's it called? One of your slides says services, and I was wondering what kind.
Well, this is any physician practice that we're talking about here. Now, are you talking about are you talking about behavioral health versus like a doctor, or what are you asking here?
Like people with disabilities have their mental health issues or behavioral issues.
I think behavioral health, I mean, if it's a physician, a doctor, then that's covered. I mean, whether you have disabilities or not, you go see a doctor, it's supposed to be doctor control of the practice.
Okay.
Mike,
Yeah, were the independent pharmacy organizations actively involved in the testimonies and support for this bill?
Yeah, they were. The independent pharmacies were. I mean, obviously the PBM lobbyists pushed back, but I mean, it was overwhelmingly like I said, it wasn't even the legislature, there was nobody voted against it basically in the legislature. So I mean, it was basically just the trade association pushed back on it, but the pharmacists, all the testimony and the independent, I think it's in the IPA or some Independent Pharmacists Association, yeah, they testified in favor of the legislation.
Simon.
Yeah, I wanted to ask about the HB 4130 that's going to be introduced next year, because you mentioned the distinction between like wholly corporate ownership and like the LLCs. So the 51% owned by physicians, that's going to apply across all different structures, like business structures, whether it's the if it was passed this next year's legislative session.
Yeah, that's correct. So
Okay.
LLCs and LLPs were not covered, so they'll just be brought under that. But again, it's practices can still get outside investors to help them expand or keep their doors open, but they just can't majority own the practice or control it.
So I just want to make sure I heard something correctly. Flip the practice, meaning buy it, rate it, and sell it. Is that right?
That's what private equity normally does.
Okay.
Because
So
that's what they're on a short timeline and they want to show profit to their investors. So that's normally what happens, and that's why a lot of even hospital systems are in trouble because of that.
So we here in Corvallis might actually expect in a few years, Optum may sell this clinic to somebody else.
Yep. As I showed in that slide, 65% of the time, it's just sold to another investment firm.
Wow. This reminds me of an article I read about weight loss groups. And I've only seen this written up once, but Weight Watchers sold itself to Heinz Ketchup. And then Heinz Ketchup sold itself to another corporation. And literally every well-known weight loss system is owned by a food processing corporation. So we'll give you some processed food to make you fat, and then we'll sell you the system to lose weight. This sort of thing has me pretty weirded out. I mean, the weirdest one of all is that the Atkins low carb diet is now owned by the same corporation with Cinnabon.
Oh, swell. Well, they got you coming and going, right? I mean, it's a
Come
great,
and go. And
it's
it
a
feels like, right,
business.
that's the effort, is to own both sides of the street, I guess,
I mean,
right?
if you're only designed to make money, it's a great business model. But if you want to keep people healthy, it's a terrible business model.
Right. Susan,
I
Susan, and then Kathy.
I'm going to answer your question, Mark. I'm on Weight Watchers as we speak. You know, I've been losing weight from it. It's not just a program. It is a support group as well. It's not because they're focused on weight loss. They're also focusing on other things besides that. And
Uh-huh.
I've been losing since then.
Okay, thank you. Kathy,
I think that, so what I'm going to say is speculation, but another disturbing, in this case, aspect of private equities owning anything is between the time that they buy an entity and sell the entity is typically fundamentally changed. So whether that's, you know, streamlining or whatever the case may be, it will be different by the time it's sold, and as much value as possible will be extracted from it. So that doesn't sound like good patient care. And I don't know that that's what would happen to Corvallis Clinic, but that is typical behavior.
Yep. Agreed.
oh, yeah, Luke.
Yeah, so if you were trying to get a practice away from either corporate ownership or private equity ownership, would the doctors be required to like buy back their shares? Or would it, like, I imagine you couldn't just like give control, like there would have to be some sort of transaction. I'm curious how that would work.
Well, really good question, really good point. And really all this is moving forward. So I don't know how I don't think they could go back. I mean, that's an interesting point. I'll have to ask Hayden Rook. Oh, by the way, I didn't even mention. So these slides that I got, they were from House Healthcare Committee meeting. So if anybody's interested to actually hear what happened there in the discussion and the public comment, you can go the HB 4130, those slides came out of a November 6th presentation last year, and the HB 4149 came out of a February 6th presentation this year in the healthcare committee. But that would be a really good question that all I can do is speculate, and my speculation is that this is kind of like a putting a finger in the dike kind of thing. Like, I think it would just apply to future transactions. I don't think they would go back and say, okay, you own, okay, you own this much of this practice, you own, 70%, you have to go back down to 51%. But it's a really good question, and I will follow up on that at a future meeting. But my assumption is it would just create, it would never ever get passed if they actually had to go back and and it has, if it was retroactive. My assumption is it would just be moving forward. And the whole point of this legislation is to keep things from getting worse.
This, yes, is that Shelley?
I'm wondering, Alex, does the committee monitor the meetings in between sessions while the bills are being formulated?
Well, actually, that's a really good question, because the material that I got this from, this was in what's called the interim session. So the November 6th meeting was between the 2023 and 2024 session, and it's called an interim session. So if you go on to OLIS, which is the state legislative information system, you can select like what session you're looking at. So it'll say 2024 session, 2023 session, and it'll say 2023, 2024 interim, and that's when this was discussed. So yes, the answer, your short answer is yes. the committees do hold hearings in between sessions and look at things like this to look at kind of do little informational sessions and look at upcoming legislation.
Well, do they take public comments during these meetings?
They do, actually. So you can,
So, because I think it's always good to get in, you know, while things are, before things get kind of wrapped up.
yeah. Now it depends because, well, you know, because if it's an informational session only, then it's just for the committee members. So it depends on whether they want, you know, if it's called a hearing, a public hearing, then the public is allowed to make comments and submit testimony. But if it's informational only, then the public can't, it's just for the committee members. So you have to kind of look at the session. You know, that's posted on the agenda, on the agendas, again, on the old list, whether it's a public hearing or informational session. If it's a work session, again, that's just for the committee members to work on stuff, and the public comment is not allowed.
Thanks.
You bet.
I think I'll jump in and give one piece of my report as part of this. So Alex has outlined some of the issues and difficulties. Next month, our speaker will be Senator Deb Patterson, who is chair of the Healthcare Committee in the Senate, and led the way in getting Senate Bill 1089 passed that brings universal health care and the governing board to Oregon in the next 3 years. She's a stalwart worker for healthcare, and perhaps much more importantly than that, she's very effective. And she will be our speaker. We probably, to make this happen, we're going to move the date from the 4th Monday to the 4th Tuesday. So you may want to just mark Tuesday, May 28th on your calendar, and she will be with us, and she's going to drive down, and we can all actually sit with her if you want to come into the room. But this is one of our, I would say, healthcare heroes. And she'll be outlining what she and they intend to try to accomplish in the next session.
So we may make it a town hall.
And we may move the meeting and make it a town hall. We haven't quite decided whether to try and have her in this small room at the Unitarian Fellowship, or, you know, if it looks like we're going to have a larger audience, and I think we very well may, we may have to have a larger room, and I think Mike has already reserved the library if we need it. So it's likely to have the feel of a town hall, but it will be our advocates meeting. And I'll introduce, and we'll still have board reports at the end. In any case, that's my main report for the night, but we'll do other folks after we're finished with Alex. But in a way, what we've got here is two meetings related to each other. Alex has told us what happened. Some of it's good, some of it was hard. Deb Patterson is going to come tell us what she thinks is going to happen next. But back to Alex. Questions for him? Comments for him?
Great work, Alex. Thanks.
Karen, Joseph.
You bet.
This is probably a very naive question, but is there no way that wide awake doctors up and down the valley can get together to form a union, or can they even get together and meet? Or is their First Amendment right been taken away? I heard something like that up here, that they couldn't.
Oh, a gag order kind of thing.
Yeah, but that's part of what the legislation, because doctors are afraid to. You know, actually, some of the doctors, you know, it was pretty incredible. Some of the doctors who testified in favor of the legislation, like there was somebody who was outside of with an emergency room doctor that stepped outside of the emergency room. You could see the, the room behind him to testify in favor of it. But it's kind of rare because of these, not, you know, gag clauses. You know, doctors are afraid of speaking out because they can be punished for it. So, you know, the answer to your question is yes, they can, but it takes extraordinary courage to speak out. And that's the point of the legislation, would allow them to do that without fear of penalty.
Mike,
Carol and I talked with a clinic doctor last week who said, I've never worked under a corporate structure before, so I've never been burned by it. Several of my colleagues are leaving already because they do not want to work under Optum. But it's going to be like the frog in the water, hot water, warm, and different doctors will have different thresholds of how warm they'll let that water get before they leave. She or he is gonna leave within the year.
wow. Okay. Other comments or questions? If, well, go ahead.
I have a comment.
Yeah,
Last, well, just a few days ago, there was a meeting that the Healthcare for All Oregon organized, and they gave us a talk about all the problems of these bills. And I must admit, I left after about 45 minutes or so because it was repetitive and we all knew it. And so I wrote to the representative who submitted the bill, and I wrote to Alex because I heard his voice after I came back from a walk, actually. And I said, maybe we should do more action, because all of the people that were at that meeting were in favor of what we're doing. They didn't need to have the same thing repeated over and over and over again, in my opinion, although I'm sure some of them benefited from it. But, you know, to have a 2 or 3 hour meeting going over these things, but they didn't go into the things that Alex did. Alex went into details of how the darn thing works. And that was more informative from my perspective. But I suggested, couldn't we get some of these people together and have them go to meetings of social groups, and I mean groups such as the groups that do things for the community's benefit, whether it's take care of getting eye protection for people who don't have access to eye doctors around the world, for instance. In other words, to groups that do some real community good and have talks, several of them in the community, about such things as this. I think this is a very important issue that most people do not know about and do not know how to participate in. And I heard back from the representative's top aide, who said he thought it was a great idea. He said the only problem is his representative doesn't have the time. So the thought was that people such as us, such as we are, could possibly organize in that way. Anyway, that's a thought, because the idea was not enough people know, and there are a lot of people making money on this, and they will be heard.
As purpose for our meetings, isn't it?
Yeah.
I think
That,
that's what we're trying to do, Bobby, with these town halls and bringing the public in. I hope that is along what you're thinking about.
yeah, and
That's, that's one of them. Yes, absolutely.
and my little follow-up to that, or what you made me think of, Bobby, was about a month ago, Mike asked the Corvallis City Council to support the, I'm sorry, what's the phrase?
The resolution,
A resolution, but on a federal,
you know, state-based universal health.
state-based, yeah, to get state-based universal healthcare ability through the feds. And on the night, and so that's presented one night, then, and, you know, a couple weeks later, then they're taking the vote, and Mike was out of town. So Bruce Thompson and I went, and we did, I'm glad we did, because we answered a few questions. It became really clear that the city council folks did not know about Senate Bill 1089 or any of the other good moves that have been made towards universal health care. And they were actually a little bit confused, a couple of them, even in the second meeting, having read what Mike wrote to them, were still confused. They thought they were maybe voting for a program for Oregon, and we had to clarify. You're not voting for universal health care for Oregon. That's actually been done. That's happened. There's a governing board that's been appointed. I had to actually say those words. So I'm going to invite the entire city council to Deb Patterson's presentation. And I think we better include the county commissioners and you know, Bobby, as you were saying, we need to start educating people about what's actually happened. We've lost a few issues. We've won a few, and no one knows. So I'm hoping after Deb comes on May 28th, a lot more people will know.